We're doing the environmental scan. Here's the desk where the computer will be sitting on. And I'm going to plug it in too. Okay, all right. Hi, my name is Bailey, and this is my physical assessment video for NR509.
Hi, my name is Adam Ward, and I give my consent for this video to be published to the Chamberlain College of Nursing for grading purposes.
Okay, so I'll begin my exam by introducing myself to the patient. So I'd say, hi, my name is Bailey, and I'll be doing your physical assessment today. And now I will inspect the facial scan. I note that it is symmetric, and there's no obvious lesions or deformities. The head is midline and symmetric, and it is the right size. All right, go ahead and sit here so that the people that are watching can see better what I'm doing. Okay, so now I will be palpating the lymph nodes, starting at the pre-articular in front of the ear, the post-articular behind the ear, the occipital, which are behind the head, and then moving on to the tonsillar, the submandibular, and the submental, and then moving down to the neck at the anterior cervical and the posterior cervical, and then the supraclavicular, which are right above the clavicles. And I did not feel any enlargements with that. So go ahead and sit back down for me, please. Move this stool out of the way. Now I will be testing cranial nerve number 5, the trigeminal nerve, which has a sensory and a motor component. I'll first test the motor component, which involves palpating the masseter muscle. So I'll put my hands over the masseter muscle. Go ahead and clench down for me. And as he's clenching, I note that there is great strength and that there are no distortions. So that is normal. Now I will test the sensory portion of the trigeminal nerve by having the patient close his eyes and identify where I'm touching. So go ahead and close your eyes for me.
Forehead, left cheek, right cheek, chin, nose.
And he was able to correctly identify all of those spots, so cranial nerve number 5 is intact. I'm going to tilt this up just a little bit. Okay. Now I'm going to test cranial nerve number 7, the facial nerve, by having the patient make a series of facial expressions for me. So the first thing I'll do is ask him to smile, and then frown, and then raise your eyebrows, puff your cheeks, and pucker your lips. Okay, good. So all of those expressions were symmetrical, and cranial nerve 7 is intact. Now I will be moving on, and I will be inspecting the ears. I will look at them bilaterally. I note that they are symmetric with no obvious lesions or discolorations or nodules. Now I will be looking inside the external auditory canal and at the tympanic membrane using my otoscope with the light turned on. I will scoot up just a little bit for me, please. I will pull the pinna up and back to better visualize. I look inside. I see that there is there's no drainage, redness, swelling, or cerumen. The tympanic membrane is pearly gray, and there's no cerumen in the middle ear. I'll do the same thing on the other side. So I'll pull up and back, looking inside. I see that there's no redness, swelling, drainage, or cerumen. The tympanic membrane is pearly gray, and there's no effusion in the middle ear. So the ears are good. Now I will palpate the tragus and the pinna, and as I'm doing this, I'm going to be feeling for any kind of nodules or tenderness. So first I will do the pinna, which is this bit of the ear here. And I do not feel any nodules. Any tenderness?
No.
And then the tragus, which is this bit. I do not feel any nodules. Any tenderness?
No.
Alright, good. Now I will be moving on, and I will be doing the whisper challenge, or whisper test, which is testing cranial nerve number 8, the acoustic nerve. So to do this, I will have you go ahead and cover one ear with your hand, and I will be whispering 3 words to you, and I want you to repeat them after I do, okay?
1, 2, 3.
Alright, now I'll come around the other side and do the same thing.
4, 5, 6.
Alright. Hearing is intact bilaterally because he was able to identify all 6 words. Now I will be moving on and I will be inspecting the eyes. And to do the eyes, I will first look at the conjunctiva and the sclera. I note that the conjunctiva is pink with no drainage and it is clear, and the sclera is white and clear. So that is good and normal. And now I will be testing the optic nerve, which is cranial nerve number 2, testing for gross visual acuity, central vision, and peripheral vision. I will first test for central vision using my Snellen pocket eye chart by standing at least 6 feet away. And I'll ask the patient to go ahead and cover one eye for me and read the lowest line that you can read.
LTFPH.
Good. Now do the same thing with the other eye.
LTFPH.
Good. Now with both eyes, read it.
LTFPH.
Good. So there is normal vision. Patient is 20/20 in the left, 20/20 in the right, and 20/20 with both eyes. So that is good. Now I will be testing the patient's peripheral vision, part of the optic nerve, cranial nerve 2. So go ahead and stand up for me so that we're at the same level. And I'm going to start waist high. Do you see my hands?
No.
Let me know when you do.
Yes.
Okay. I'm going to come above. Do you see my hands?
No.
Let me know when you do.
Yes.
Okay. And I'm going to go below. Do you see my hands?
No.
Let me know when you do.
Yes.
All right, good. Cranial nerve number 2, the peripheral vision is intact. So go ahead and sit back down for me. Just the camera. Ooh. All right. Now I will be moving on and I will check the, using my ophthalmoscope light source, I will be checking the pupil's reaction to light. So I will go from the side. Turn this a little bit so they can see what I'm doing. And I want you to look directly at my nose. I'll be coming from either side. Okay. And both pupils constricted equally, and they were equal when interacted to light. And they're about 2 millimeters in size, so that is normal. Now I will be testing cranial nerves 3, 4, and 6. Cranial nerve number 3 is the oculomotor nerve. Cranial nerve 4 is the trochlear nerve. Cranial nerve 6 is the abducens nerve. And to do this, I will be making an H pattern with my hands to test the extraocular muscles of the eye. So just follow with your eyes only. Alright, all EOMs are intact. Now I will be moving on and I will inspect the nose. So to do the nose, I will first just look at it, inspect it. I notice that it is midline and straight with no obvious fractures. And I will again use my otoscope with the light source. And I'm going to gently tip up with my thumb to look inside. I see that the septum is midline with no deviations or swelling. The turbinates are a healthy pink and moist. I'll do the same thing on the other side. So I'm going to use my thumb to tilt up. I'm looking inside. I see that the septum is midline with no deviations and there's no swelling. The turbinates are a healthy pink and moist. So that is normal. Okay. Now I will be palpating the sinuses. So to do this, I will be feeling for any tenderness. So I'll first palpate the frontal sinuses. Any tenderness?
No.
And then the maxillary sinuses. Any tenderness?
No.
All right, good. So there's no tenderness with sinus palpation. Now I will be inspecting the mouth. So first, I will look at the lips. I see the lips are pink and moist. And open your mouth for me. I'm just going to use my light source to see better. Let me look at your teeth. The teeth are, there's no obvious signs of decay or cracking in the teeth. The gums are a healthy pink and moist with no lesions. The buccal mucosa on either side are a healthy pink and moist. The hard and soft palates are a healthy pink and moist with no lesions. The floor of the mouth is a healthy pink and moist with no lesions. And stick out your tongue for me. And the tongue is smooth and a healthy pink and moist. And then I'm going to look at the back. And the posterior pharynx is also a healthy pink and moist with no lesions or postnasal drainage. And he does not have tonsils, so I will not be grading them. Now, I won't be testing cranial nerve number 9, which is the glossopharyngeal nerve, because that is the gag reflex, and we won't be testing that for this exam. But I will go ahead and test cranial nerve number 10, which is the vagus nerve. by having the patient stick out his tongue and say ah, and be watching the uvula. So go ahead and stick out your tongue and say ah. Okay. I see that the uvula does rise symmetrically with phonation, so that is a normal finding. Now I will be testing cranial nerve number 12, which is the hypoglossal nerve, by asking the patient to stick out his tongue and go side to side with the tongue. So go ahead and do that for me. Good. Alright, so he's able to do that, so cranial nerve number 12 is intact. Now I will palpate the temporomandibular joint, the TMJ joint, and as I'm doing this, I'm going to be feeling for any subluxations, crepitus, or clicking. So go ahead and open your mouth for me. Now close. I did not feel any crepitus or clicking. Any kind of tenderness when you did that?
No.
Alright, good. So that is normal. Now I will move on and I will inspect the neck. I see that the neck has no obvious deformities and that it is symmetric and there's no lesions and the skin is intact with no discolorations. Now I will be palpating the trachea. I note that the trachea is midline and symmetric. And now I'll be palpating the thyroid. So to palpate the thyroid, I will find the cricoid process and the suprasternal notch. And I'll put my hands in between the two landmarks here. And I'll retract on one side. And as the patient swallows, I'm going to be feeling the thyroid size and if there's any obvious lesions or anything. So go ahead and swallow. Good. I'll do the same thing on this side, so I'll retract. Go ahead and swallow for me. Alright, so there's no obvious lesions and there was no abnormalities felt during palpation. Now I will be palpating the carotid arteries one at a time. Okay. Those are both equal and bounding bilaterally. And now I will be auscultating over the carotid arteries. I'm listening for any kind of bruits, and I'll use the bell of my stethoscope to do this. So as you're doing this, I'd like you to take a deep breath and hold it so that your breath sounds do not distort any of the sounds I might hear, okay? Go ahead and take a deep breath and hold it. Good, and release. Same thing on the other side. Go ahead and take a deep breath and release. Good. I did not hear any kind of abnormal sounds or bruits. Now I will be, let's see. I will be testing the range of motion of the neck. So to do this, I will ask you to put your chin down to your clavicle area for flexion, and then straighten back up. And look up at the ceiling for extension. Good. Now rotate your chin over each shoulder for extension, or rotation. Good. Rotate. Good. Now I want you to do lateral flexion. To do this, you got to put your ear down to your shoulder. Good. Now do the other side. Alright, good. So he was able to do all of those motions symmetrically. So range of motion of the neck is intact. Now I will be testing the cranial nerve number 11, which is the spinal accessory nerve, by putting my hands on his shoulders and asking him to shrug. Go ahead and shrug for me. Good. He was able to do that, so cranial nerve number 11, the spinal accessory nerve, is intact. Now I will be moving on, and I will be listening to the patient's heart sounds. I will be first use the diaphragm of my stethoscope, and then I'll use the bell. So I will start at the aortic point, the aortic valve, which is at the second intercostal space, right sternal border. Moving on to pulmonic valve, which is at the second intercostal space, left sternal border. Going down to Erb's point, which is at the third intercostal space, left sternal border. And then going on to the tricuspid valve, which is at the fourth intercostal space, left sternal border. And then the mitral valve, which is at the midclavicular line, left fifth intercostal space. Alright, and I did not hear any extra sounds such as gasps, murmurs, or rubs, and I will do the same thing with my bell. So, starting at the aortic valve, which is at the second intercostal space, right sternal border, the the pulmonic valve, second intercostal space, left sternal border. Erb's point, third intercostal space, left sternal border. Tricuspid valve, fourth intercostal space, left sternal border. And then the mitral valve, which is at the fifth intercostal space, mid-clavicular line. I don't know if when I did the listen with my diaphragm, if I said that this point is aortic, pulmonic, Erb's, tricuspid, mitral. Just wanted to make sure I said all that right. Sure. All right. Now, I did not hear any extra heart sounds, and I heard S1 and S2, which is a normal finding. Now I will be inspecting the chest, and I note that there is no obvious deformities and that it is symmetric and that the chest rises and falls equally with his breathing, so that's normal. Now I will be auscultating my lung sounds, so I will do that with the diaphragm of my stethoscope. I'll just be going over about 6 points here. Just breathe normally. Okay, and I did not hear any adventitious lung sounds at this time, and the breath sounds were all present in all lung fields. So go ahead and stand up for me, and I'm going to auscultate your posterior lung sounds. Okay. Again, I'll be using the diaphragm of my stethoscope. For these, I will start above the scapula, and I'll be working my way down in a side-by-side motion. Okay, just breathe normally. Hitting all 8 points. Making sure I include the right middle lobe. Okay, you can sit back down. And all breath sounds were clear with no adventitious sounds heard. Now I will be inspecting the lower extremities, or the upper extremities. So first I will look at your fingers and your hand joints. So I see that the joints, there's no obvious lesions or discolorations or swelling or nodules. Any tenderness in your joints?
No.
Okay. I'll check the capillary refill. So to do this, I will hold down until it turns white on the nail, and then I'll release, and when I release, I'm checking to see how long it takes to turn pink. And that was less than 3 seconds. I turn this down so you can see. And then on the other side, that's less than 3 seconds too, so that is a normal finding. Now I will be palpating the radial pulses. So just go here. And those are equal bilaterally, about 2+, so that is normal. Now I'll go ahead and feel your grip strength. So go ahead and grab my hands and squeeze. Good, 5 out of 5 grip strength. And now I will be testing range of motion of your elbow. So to do this, just go ahead and straighten your arm. We will do, and for this exam, we're only going to be doing it unilaterally, but for the purposes of a real exam, we would be doing it bilaterally. So we will flex the elbow and then extend the elbow. So normal range of motion for the elbow. Now I want to go ahead and test his bicep and tricep strength. So go ahead and put your arms up like this for me. And I want you to push against resistance. Good. Now pull me in. Good. 5 out of 5 strength for the triceps and the biceps. That is normal. Now I will be testing range of motion of the shoulder. So full passive range of motion of the shoulder. So to do this, I will do flexion, extension, internal rotation, external rotation, abduction, and adduction. And all of those, the range of motion for the shoulder is intact, and he was able to do all of those motions, so that is normal. Now I will be testing cerebellar coordination using rapid alternating movements. I've got 2 tests to do this. So for the first one, we will be doing the alternating finger. So I want you to put your fingers, or your ring finger, or your forefinger on your thumb, then your ring finger, and then so on, just like this. Go ahead and just do that as quickly as you can. Good. Good coordination. Now I will be doing the rapid alternating movements with your hands. So on your thighs, I want you to flip them up and then flip them down, and just keep doing that. Good. So that is good alternating movements with both of those tests, so there's good coordination. Now I will be testing the deep tendon reflexes using my hammer, And to do this, I will first test the bicep tendon. So I will support his I will support his hand or his arm with my arm, and I will put my thumb on the antecubital fossa, or the medial aspect of the antecubital fossa, and I will strike my thumbnail with the pointy end of the hammer. Okay, and that was a good reflex there. Now I'll be moving on, and I will be testing the patellar reflex of the knee. So I will be using the long end of the hammer. Yep, go ahead and relax your legs. And good reflex there. And now I will be testing the Achilles reflex. So I will gently dorsiflex the foot just a little bit. And I will be tapping with the long end as well. Good reflex there. So that is normal. All right. Now I will be moving on, and I will go ahead and ask the patient to lay down for the abdominal exam. And I will adjust the camera just a little bit so I'm not going to block the view of this. That should be good. I'm going to pull up your shirt just a little bit. All right, so the first thing I'm going to do is I'm going to inspect the abdomen. I noticed that the abdomen, for contour, symmetry, and any kind of abnormal findings, that the abdomen is flat, it's symmetric, there's no lesions or discolorations of the skin, so that is normal. I will first auscultate the bowel sounds in all 4 quadrants using the diaphragm of my stethoscope. And bowel sounds are present in all 4 quadrants. Now I will be, make this up just a little bit. Now I will be auscultating for any kind of bruise that I hear in the abdominal area, and I will use the bell of my stethoscope to do this. So I will start at the aortic area, which is midline and right below the xiphoid process. And then moving on to the left renal, which is lateral and above the umbilicus. The right renal, which is to the right and above the umbilicus. The right iliac, which is to the right and below the umbilicus. And then the left iliac, which is to the left and below the umbilicus. And I did not hear any adventitious sounds or any kind of bruise or abnormal sounds with that. Now I will palpate the abdomen in all 4 quadrants for any tenderness or masses. Any tenderness or masses there?
No.
All right, well, okay, good. And I did not feel any masses either with that. Now I will be percussing in all 4 quadrants, listening for tympany, dullness, or flatness. And I did not hear any tympany, dullness, or flatness. Now I will be palpating for the spleen and the liver. So to do this, I will have the patient, I'm going to put my left hand underneath the patient's right side to support him. I'm going to feel for the liver first. And I will find the midline, or the midline process, midclavicular line area. And I will use my hand to find the costovertebral angle. And I will be pushing in deep and inward as he breathes in. So go ahead and take a big deep breath in for me. Okay. And I cannot feel the liver, so that is a normal finding. And now I'll have you turn, just pick your knee up, and turn just slightly towards me, just a little bit, so we can, and I will put my hand under the patient's his left side again. I'm feeling for the spleen. So I'll do the same thing. So I'll take my right hand and I'll find the costovertebral angle. And when I'm doing this, I'm going to be pushing upwards and downwards, trying to feel the spleen right under the costovertebral angle. So go ahead and do that for me. Take a big deep breath in. Good. And I do not feel the spleen, which is also a normal finding. And the last thing I'm going to do with the abdominal inspection is the Bloomberg sign. So to do this, I'm going to be going directly into the patient's abdomen, and if there's any kind of rebound tenderness, that would be a positive Bloomberg. So, any tenderness?
No.
Any tenderness?
No.
All right, so that is a negative Bloomberg, which is normal. Now I will be moving on to the lower extremities. And I will first just inspect them. And I note that there is no edema or abnormalities, the skin is intact, and the skin integrity is good. Now I will be testing range of motion of the hip first. So to do that, we have limited room. So I will be flexing first, flexing the knee, which in turn is flexing the hip. And then I will be doing abduction away from the midline, adduction across the midline, and then internal rotation and external rotation. So that was normal range of motion for the hip. And now I'll also be testing range of motion of the knee. So to do this, and we're not testing extension for the hip for this exam. So for the knee, I will do flexion and extension. And that is normal as well. Now I will be testing the strength of the knee. So go ahead and put your legs up for me, both of them, please. I want you to push against my hands. Good. All right. And then pull against them. Good. So there's 5 out of 5 strengths with the knees. All right. You can relax your legs for me. And now I'm going to be moving on to the feet. And I will first test range of motion of the ankle. So to do this, I would do plantar flex, point the toes down and the whole ankle down like he's pushing on the gas. And then I would dorsiflex up, and then rotation. Good range of motion for the ankle. Now I'll also be testing ankle strength. So I want you to go ahead and push down like you're pushing on the gas for plantar flexion. Good. Now push up for dorsiflexion. Good. 5 out of 5 strength there. And I will also be testing the dorsalis pedis pulses on both feet bilaterally. And they are equal and about 2+. All right, go ahead and stand up for me now. I'm going to be checking your spine. Okay, stand just a little bit forward for me. All right, so I'm going to be palpating and inspecting the spine for any kind of unexpected curvatures or misalignment. I don't feel anything at all. The spine feels straight. Any kind of tenderness when I do this?
No.
Okay, good. Now I'll test range of motion of the spine. So to do this, scoot just a little bit backwards. I will first have you bend down and touch your toes, which is flexion, all right? And then lean backwards for extension. Good, okay. Now I want you to rotate to the right and then rotate to the left for rotation. Good. Now lateral flexion, I want you to take your left hand and try to reach down on your side. Good. That's lateral flexion. Now do the same thing on the right side. Good. Okay. Now I'm going to be testing the Romberg sign, which involves the patient standing still with his arms by his side and closing his eyes, and I'm going to be looking for any kind of swaying. So go ahead and close your eyes for me. And I would be doing this for about 20 seconds. And I note that there is no swaying, so that would be a negative Romberg, which is normal. And the last thing I'm going to have the patient do is I just want to assess his gait. So I will just have him walk just a few steps. Go ahead and walk for me. Good. Now turn around. Good. Gait is normal. And that concludes the exam.